Heard from, welcome to the panel discussion following the lecture that we heard from Brandy Leach just a few minutes ago. And hopefully all of you have had a chance to view her excellent presentation. I want to welcome our panel today. And first of all, we have Brandy Leach, who is, as you know, a genetic counselor and who works with Invitae. We have Dayo Fadilou, who's a medical oncologist, has been working in Africa and has clinical experience in a lot of different levels. And we also have Diane Kohler, who is a genetic counselor from the Dana-Farber Cancer Institute. And Diane will be giving lectures next week on the counseling aspects, cancer counseling aspects in the next section of the course. So welcome everybody, welcome to this session. We have been doing this daily through the course, and people have been writing in questions. Today's focus, because of the expertise we have, is sort of the genetic testing components, the interpretation and curation of mutations and things like that. So let's get started because we already have a few questions in the chat. The first comes from Sangeeta Prabkaran, who is, are various numbers of gene panel testing? How is the genetic panel number of genes selected by the genetic counselor? And Brandy, if you are there, would you give a start to that? And I'd also like to ask Diane, who does this day to day as well.
Yeah, I'd be happy to answer that. Thank you so much for the question. So in my experience, when I worked in clinic, I found that we tended to like using comprehensive panels. So those that covered multiple disease types like breast, ovarian, uterine, colorectal, all in one panel, because studies have shown that that's where you have your greatest variant detection rate is when you use a comprehensive panel. And if you stick to a disease-specific panel, you might miss variants that you wouldn't otherwise have predicted from the family history. So in my clinical practice where I was before Invitae, we tended to use comprehensive panels, but we also recognized there were situations where maybe that wasn't always the right fit for the patient. So for example, if it was a woman who was newly diagnosed with breast cancer and was trying to make surgical decisions to treat her breast cancer and was maybe too overwhelmed by her current treatment process and wasn't ready to get information about other genes, we might limit that to a breast cancer panel that turns around quickly and gives that woman the information she needs to make her surgical decision. And then after she gets through that process, go back and reevaluate if a more comprehensive panel would be appropriate at a separate point in time. So generally, we were using comprehensive panels, but there were select times where we were using more disease-specific panels.
Thanks. And I know that different clinicians have different philosophies based on their experience or their perspective on this. Diane, do you want to give anything about how you in the clinic or the people you work with make these decisions?
Yeah, absolutely. And so I would echo everything Brandy said. We also tend to kind of default to these comprehensive multi-cancer panels with a real focus on actionability. So even if, we're not seeing a family history of colon cancer that the patient knows of, we think it's reasonable to include genes related to colon cancer for all patients who are interested in that because it's actionable. We can make recommendations for colonoscopy screening as a preventative method if we learn that somebody has a higher than average risk for colorectal cancer. So we tend to present these multi-cancer panels as our standard of care. Usually the minimum number of genes we include on that's about 35 to cover genes related to breast, gynecologic, and colorectal cancer risk. But we certainly can modify that patient by patient. Some patients are not interested in that. They really want something more targeted. We also do see that other clinicians sometimes feel more comfortable ordering a more targeted panel if they don't feel that they're prepared to manage somebody who has a mutation in any gene on that list. So sometimes if it's a breast provider who's ordering a test, they might not feel as comfortable including genes related to colorectal cancer risk that might be a little outside of their scope of practice.
Thanks. I think that while there is a lot of science involved in these decisions and a lot of it is not, it's subjective. It is based on clinician experience and preferences. And I think that that's something that, is very difficult to quantify or answer, but it is something that, that as you gain experience, I'm sure you'll have a better sense of how you want to manage a patient. Again, next week, I think we'll learn a lot more about this process when we hear about the counseling and decision-making and follow-up. So there is a question from Kim about what is the turnaround time for panel testing in clinical settings? And again, Diane or Brandy, whoever wants to take that. And if you could also at the same time, if there's a way to address what this might look like in Africa, because again, if you're in Boston, there may be one thing. In for Africans, it may be quite different. And I don't know, Brandy, or maybe Diane knows too, but Brandy may have some experience working globally with sending tests from other countries or something like that. If you can comment on that, I think that'd be helpful to our audience.
Yeah, so in the United States, it generally takes about 2 to 3 weeks for us to get a comprehensive panel back. But as I had talked about, the STAT breast cancer panel are results that we can get back in about 7 to 10 days. And I think from the standpoint of ordering from Africa, the process once the sample gets to our lab would be the same. I think where we might see a difference is just a couple added days at the beginning for the sample to arrive at the lab. So I still would anticipate we'd be somewhere in that 3-week range for results to come back.
That's great. Yesterday, a question arose about shipping to Africa and the samples that come out of Africa that may have, there may be local or national regulations about shipping biosamples, things like that. Do you have, Brandy, any experience in dealing with any of the regulatory or special issues for global shipment of samples for testing?
Yeah, that's a really great question. And we see a lot of variety from country to country. So we try in general to start when we know we have a collaboration or a new center that wants to order testing, to try to start with a small pilot to see how many days it takes to get through those regulatory steps before kind of opening the floodgates and massively sending samples. So I don't know if that has yet been conducted as it relates to our Rwanda project, but I think that would be an important step that we need to incorporate into the process.
Great, thank you. I want to also welcome Achille Manarakiza here, who from Rwanda, who is joining the panel right now. And I don't know if anybody else wants to comment on the question of sample shipping. I don't know if Achille or Dio or somebody has had experience with this in Africa yet.
Yeah, so we have some experience shipping, not specifically for genetic testing, but shipping for other purposes. One of the comments I was making yesterday is, the type of sample does matter. So shipping blood falls into a different category than shipping other types of samples. And also, I guess the potential infectiousness of the sample. So something that is fixed and like a paraffin fixed block sort of falls in a different category. And I think the regulations sort of vary from country to country, but also vary based on the whoever is doing the shipping partner. So I think that's something that will have to be individualized to different places.
We have had a great deal of experience shipping samples to and from Africa and within between African countries within Africa. And there we can provide some information for people who are interested in this related to getting export licenses and certificates so that biosamples can be shipped without having the problems of being stopped at borders and getting the right paperwork so that customs officers will respond appropriately. So that's a slightly separate question, but we're glad to provide some information about that if people are really interested in learning more. There are a couple of technical questions, and again, anyone can answer if they like, but it sounds like these might be Brandy questions. These are technical questions about sequencing and quality control and things like that. So the question from Francis Makoka is that is NGS, next generation sequencing, to identify pathogenic SNPs or CNVs in cancer diagnosis and screening already in use? And how would NGS be adopted in routine diagnosis in Africa, where we have a dearth of skills and resources? And I like Brandy to answer, but I can just say that I think most of the clinically relevant work that people are doing for genetic testing is done by companies in the US and other places, that most places, even in the US, even in Europe, are not doing in-house testing. Most of the work that's done clinically is done by testing companies. Most of the work that's being done in research is being done locally in-house, and that there are CLIA approved or clinical labs that people have developed for various purposes. But I don't know of very many people who actually do clinical genetic testing on their own. So Brandy, do you want to, or anyone else want to add about anything to that?
Yeah, I completely agree, Tim. Really, I think the expertise and the equipment and everything in the process that is needed really requires a large multidisciplinary team with lots of resources that just aren't feasible for individual institutions to have. So a lot of this is sent out to commercial laboratories. We are routinely using NGS, and the company that I currently work for, as well as the other commercial laboratories in the United States, all have processes worked out for how to identify copy number variants and how to filter the sequencing information from NGS through their pipeline to identify various types of variants or large rearrangements that can occur in the genes. So that's a pretty routine process that has been pretty well established, I would say, at all of the commercial laboratories in the United States and Europe.
Does anybody else want to add to that? I think it's very clear that for some of the important research work, it is important. It is going to be critical to develop these resources locally. And there are other molecular testing kinds of things that molecular pathology labs might like to have locally. But again, for germline genetic testing, it's not been the practice to do these things locally. So again, something to discuss. Related to that, there's a couple of other questions. Let's stay on the topic of quality control. The Chem is asking about quality DNA extraction protocols for good results, quality control in testing, things like that. Again, using a commercial lab, those things are really worked out. Doing that in your own local setting would require, building those protocols and doing quality control testing and checks all the time. But I don't know if somebody would like to talk about DNA quality and quality control in general. Anyone who might feel comfortable answering that? So I can just say that there are plenty of quality control measures that one takes in labs. And again, part of that quality control is dependent on whether you're doing a research protocol or a clinical protocol. So we in the United States have standards for clinical data, and that has to do with how the sample is handled, the chain of control of the sample, helping to avoid sample mix-ups or sample, mistakes in sample handling so that patients don't you don't assay or report out the wrong result for a different patient or something like that. So there are very clear standards, and they are written out for the United States. And so again, that's a CLIA, which is the Clinical Laboratory Improvement Act. It's, you know, regulation that we have that allows for quality control of clinical samples to be, you know, optimized. And so you can look at those guidelines and apply them in your own setting if what you're trying to do is something that's clinical. For research, it's very different. It really relies on your protocol and the science that you're doing. It relies on your IRB and your ethics approval and making sure that you're compliant with whatever ethical and quality control issues that are relevant to the protocol you're doing for research. So really, it depends a little bit on why you're doing the DNA extraction, why you're doing the biosample work and things like that. I don't know if anybody has anything to add to that.
The only other thing I would say to that is, as a clinician, when I was ordering testing, this is a completely blind process to you. This is all happening on the back end in the lab. And really the only time that you would hear anything about, or in my experience, the only time I heard anything about there not being enough quality DNA tended to occur when we were submitting saliva samples. So there is often not an issue with blood, but with saliva, we did have more patients that had insufficient quality DNA. And it was often my experience, those were the patients providing their own saliva samples that weren't witnessed by me, and they weren't following the well-written instructions that were in the kits. And so there just wasn't enough DNA that they could extract out of the saliva sample. So as a clinician, mostly, you know, this did not come up as an issue until we were more routinely sending patient saliva kits to collect the sample on their own. And I think they just weren't following instructions well.
And fortunately,
I saw Diane nodding.
Yeah, I think fortunately,
yes, I've had the same exact experience.
Yeah. I think that, you know, the technology has come along very far. And, you know, it used to be you had to draw blood in order to get adequate DNA for these kinds of tests. So now saliva kits, spit kits are more the norm. And in fact, we have used buccal brushes, not even spit, but just brushes, and gotten good results. And so I think the technology has gotten to the point that failures are relatively rare. I mean, again, they're not unheard of, but that the technology has gotten pretty good to take samples that are even poor quality and get clinically meaningful results. But it's never 100%. There's definitely issues and requirements for resampling and things like that. Let me just move. There's a couple questions that are very general about clarifying the difference between familial and hereditary cancers. And so, you know, and then really how you start thinking about this, you know, and we take a lot of that for granted, but let me just say that the distinction between familial and hereditary cancers is somewhat arbitrary. It's a continuum. If you have a cancer, as Brandy said in her lecture, all cancers are hereditary or are genetic. Not all are hereditary, meaning they're not all passed down in a Mendelian way, and so that the pattern of cancers that you see look hereditary. And that has to do with the fact that there's incomplete penetrance. Not all the cancers appear exactly the same. They're not all diagnosed at the same age. There might be different kinds of cancers, but you can identify some quote unquote hereditary patterns by looking at the pedigree and understanding what this pattern implies to you and whether it appears to be Mendelian on a pedigree. But that and familial might just mean that there's a little bit less of that. It might be a little bit less of an intense, clearly autosomal dominant across generations pattern. It might be that there's an excess of cancer in a family. And that might be a very nebulous, gray kind of an impression you get by looking at a family. So again, two things. One is, as Brandy said, all of these cancers have an underlying genetic component. And so there's genetics going on, whether it's germline or somatic or both. And then there's what you see in a family, in a pedigree when you're looking at them. And that may look familial, it may look hereditary, and it becomes part of training to identify these patterns and to identify clear syndromes where they exist. And so I'd like to hear the clinicians speak about this in a second, but I think that it's not something that is very, very clearly defined so that you can say, well, this is hereditary and this is not. Sometimes you can, but sometimes you can't. And then if the clinicians could also answer the question about what's the best way to start? What's the best way to think about getting these data, collecting it, et cetera. So please, anybody who'd like to jump in.
Yeah, I mean, so normally when I'm using the term hereditary with patients, I'm usually referring to when we have identified a specific gene mutation or when they might meet criteria for a genetic syndrome just based on the clinical features we're seeing in a family. So some syndromes have really clear criteria just based on clinical features in the absence of a genetic test, where we may still be able to diagnose them with a hereditary cancer syndrome, even if we haven't found anything in the genetics. But typically, if we're using that hereditary label, it means we've found a mutation in a gene that we can kind of attribute the cancers in the family to. When we've done testing on someone and we kind of feel like, well, we should have found a mutation, we still see this pattern, we're still seeing more than the average amount of cancer in the family, that's where we might put that familial label on, meaning we haven't really been able to pinpoint exactly what hereditary syndrome's going on, or if it's some combination of genes and environment that are shared with family members, but we're still kind of seeing more than the average amount of cancer that might fall into that kind of familial bucket for describing cancers. And in terms of kind of where to start, I think that's a tough one, but I think our most informative tool is family history, just starting to ask patients what they know about the cancers in their family. Some people don't know much at all about their family history, and some families don't really talk about this with each other. But I think it's helpful to just start asking patients if anyone in their family's been diagnosed with cancer, what details they know about that. I know in some of the lectures for next week, there's more of a discussion about, how to take a targeted cancer family history. But I think that's always the best starting place for us.
Thanks. Would others like to? Please, yeah.
Yeah. So in regards to a more resource constrained setting, as Diane just said, it's really about the history. I have a set of siblings that I follow that have breast cancer. The first one got it at 35. The second got it at 30. That already highlights a need of genetic sequencing in that family already. They both have, interestingly, the same histological subtype of breast cancer. Besides that, I also have a few men that I follow who have had prostate cancer below 50 years of age. The youngest is 45. So that already highlights a little bit of interest in terms of genetics. The other thing now that seems to be systematic is that they seem to have an aggressive disease up front whenever they come to you in the clinic. So the pattern that tells you that there is something in the family that is of interest, and that there is something, once again, in the disease of those patients that makes it aggressive up front, and that tends to set them apart from the usual common presentation of other patients with the same histology and disease, makes it the very starting point, at least in the lowest possible resource constraint settings that we in Africa have. Now, what that means in the outset, it means that even if you really can't save them, or even if you really can't possibly, quote unquote, cure them, you might prevent downstream whoever in the family could be at risk of having it. So you really have to think in a broad term, in the sense of, I might be treating this patient, but there are more behind them, more in the village, more in the family that need this type of intervention early on, and to know the risk of developing potentially aggressive disease. So another subset that we often overlook here is that for many patients, we tend to have not only aggressive diseases, but the diseases that seem to not respond to treatment, to conventional treatment as well. So in that sense, when you are out of options, and here I'm speaking about patients to whom I even get to apalutamide in prostate cancer, or patients who even get to a third line for breast cancers, you'd want to still explore the variety of medical intervention that genetic workup can provide around that. So it not only has a prevention, it has a cure, but also it provides options whenever you have limited options to provide to the patients. Luckily, to some of these patients, they might be able to afford, or some insurances might be able to pay for it. But sadly, it is not something that is systematic in all other populations, or all other spheres, pretty much of income. So, but at least it gives you a way, it gives you a room to start, it gives you somewhere to start from.
Yeah, great. Any other comments on that? There are a few questions up that are more technical, so let's start with those, and then there are a number of clinically oriented questions. So clinicians, get ready for those in a minute too. There's a couple questions here about the data, the sequence data, the genomics data, and the bioinformatics pipelines for variant analysis. So first of all, there are a number of bioinformatic analyses that are available that you can actually feed into, and we can put some of those general pipelines for variant calling and things like that up on a website for your information. There are reference places, for example, ClinVar, that is a resource that tells you, identifies variants that are pathogenic or of unknown significance, et cetera. So there are public resources that people can check. And then, of course, each of the companies has their pipelines as well. So there are many resources like that that you can access, both that you can do analysis with, but also just check against any variant that you find, whether it's pathogenic or not, through some of these common databases. But maybe Brandy, I don't know if you can comment on some of the pipelines that are used in your company or others, and if anybody else wants to comment on that as well.
Yeah, I would say the pipelines for the commercial companies are probably proprietary and not shared publicly, but certainly in the research space, as Tim had mentioned, there are lots of available resources through which you can put your own sequencing data through, or check variant interpretation. But the commercial laboratories, I don't believe share their pipeline publicly.
Yeah, that's right. But again, if you're testing using a company, they will put their pipeline into the report that you get, and so you can understand how they've called something. And I think it's important, and I'd love to hear the others comment on this, that they're not always exactly the same. You don't necessarily get the same result or call from different sources, and that can be confusing. And it partly depends on what variants they've observed, either a company or one of the these non-proprietary sources. And sometimes you have to make decisions. I don't know if Diane, maybe you want to comment on that. I'm sure you face that from time to time.
Yeah, so obviously with each lab using their own slightly different pipeline, we expect that they're not going to all be in exact agreement with each other on variant interpretation of every variant. So usually when we get a report back, especially if there's an uncertain variant on there, we will routinely look it up in ClinVar, like the resource that Tim mentioned, and just see if there's other reporting labs that might have a different take on it, might report it as a different interpretation. So if we have something that's uncertain at one lab, but other labs are calling it pathogenic or likely pathogenic, we might be more inclined to treat that variant as if it's pathogenic, treat it like a clinically actionable result, versus if other labs are all in agreement that it's uncertain, or some labs are calling it benign or likely benign, we're unlikely to act on that variant. So we do routinely kind of do a little more digging, particularly into uncertain results, just to make sure we're doing our due diligence and seeing if other labs are in agreement.
Can I ask a related question to Diane or Brandy? So patients who might have uncertain results, is there some sort of a routine way of keeping track of those patients in the future? Or how does this, how does the team do this clinically versus on the test and lab standpoint, in case something changes in the future?
Yeah, so I think that's another benefit of using the commercial labs is they're all very good at staying on top of this, and Brandy can probably speak to this better than I can, but they will routinely reclassify variants as they learn new information, as new studies are done, and they will send us an updated report with any variant reclassifications. And then as the clinicians, we make sure that we have a method of getting those reports out to patients. So we make sure that, if the genetic counselor who saw them originally is no longer here, that it gets forwarded to somebody else, and we contact the patient to disclose the updated report to them.
Great.
I bring it up just considering doing this in some parts of the world in which, there might be barriers in getting in touch with people appropriately, or the relationship between clinicians and reaching patients. So just another level of consideration to think about.
Yeah, and we do sometimes struggle with recontact because sometimes it's been years since we got their initial report when we get a reclassification. So sometimes patients have moved, or sometimes they've passed away and we don't have a new contact person. So we try to emphasize to patients that it's important to keep us updated with if they move or at a different location, or to give us another person we can contact about their results if it ever changes in the future. But this is a challenge across the board.
Yeah, I agree. And especially with using panels. So when I was at Cleveland Clinic, if you are ordering these larger panels, you do have a higher chance of finding the variants of uncertain significance. And we know that about 90% of those VUSs will eventually be downgraded to benign, and only about 10% will be reclassified as pathogenic or harmful. So we started to run into the challenge too, where we just had a large volume of these variants that were being downgraded to benign, and it required a lot of resource to track down these patients and communicate that information to them. So, we had to find ways to readjust our workflows to be able to reach back out to these patients. But I totally agree with Diane. This would not be feasible as a clinician to track these VUSs on our own, and we really had to rely on the commercial labs to issue new reports to us to know when we then needed to reinitiate contact with the patients.
Great, very helpful. There are a couple of more sort of clinically oriented questions, and I point out to you again, next week, Diane and her colleagues at Dana-Farber will be giving 3 lectures on some of these counseling issues, but I thought these questions coming up now, I think the panel will be able to address some. So let me just mention a couple of them. There's a couple of questions that talk about seeing multiple members in the family with similar cancers but no germline mutation. So it looks suspicious, but you don't find anything. And what do you do in families with this has come up in a couple of the different questions. And so maybe all of the clinicians can talk about how you deal with families that appear to have something and there's no germline mutation detected, or alternatively, is there a germline mutation detected without a family history and without, with these complex decisions and complex management issues? What do you do next? I don't know who would like to start, but maybe Diane can start, but others can join in.
Yeah, I'm happy to start. So for the first part of that question, what if we see this striking family history and we can't find a germline mutation? That's probably what we would put into that kind of familial bucket. We'd call it a familial cancer, meaning we don't really know exactly what's causing it. We do often still make medical management recommendations based on the family history alone. And there are some risk models that I know will be talked about next week a little bit to help make those decisions. So for instance, if somebody has a striking history of breast cancer, especially early onset breast cancer, and you're seeing a relative in this family who has not had a breast cancer diagnosis, you might recommend doing some extra breast cancer screening for her, or starting that screening at a younger age, just based on family history alone, even without a germline mutation, because it still looks like she might have a higher than average risk, even if we can't pinpoint exactly why. The same often goes for colonoscopy screening. If there's a striking history of colon cancer, but no gene mutation, there still might be recommendations for family members, even without testing. In the reverse, in cases where we find a gene mutation that's either unrelated to the family history or we don't see any family history, that's concerning. We still usually will follow whatever guidelines are in place for that particular gene. So the guidelines we most often use for screening are from NCCN. So they have really detailed kind of gene by gene guidance for how to think about medical management and screening for cancer. And that's usually regardless of the family history, just because we know enough data about these genes and the risks associated with them that usually still seems appropriate to recommend certain screening and prevention.
I'd love to hear from the others about how they manage these situations where there's clearly something going on, but it hasn't been or can't be detected. I don't know, Ashiel or Brandy or Dio, if you've had that experience, and is it any different than what Diane just said?
I think it's, I think Diane sort of explained it the way I would have explained it as well. Especially, the first question, being mindful of how screening recommendations change just depending on family history alone, even in the absence of finding any specific mutations. So I think you give the example of breast cancer, but it's also similar for colon cancer as well. So the recommendations on when to start screening are different based on family history. Clearly, I think, perhaps one of the other things to also mention is screening might not necessarily be widely available in many places, but identifying these high risk populations, either based on a test or based on family history, can help target screening resources. So these are the people who certainly should, who are quite high risk, who, if there were limited screening resources, these would be the people who should get screened. So I think that's the only additional thing I'll add.
Yeah. Thanks. There's a related question here from Amanda Krause about family history being deceiving, where there's been poor medical care history and people are not always diagnosed. And I'd like to hear a little bit about people with experience in Africa, because this came up before. In the US, we have sometimes difficulty in identifying the correct family history or the accurate family history. In Africa, I'm assuming that similar kinds of things can happen, but it might be different because the family dynamic is different, medical health care is different, and this information just might not always be available. So when we're talking about families with hereditary patterns of cancer, there might also be families that have that pattern, but we don't see it. It isn't properly annotated. Does either Ashiel or Dio or somebody like to comment on that?
Certainly. So what Amanda Krause is saying is very key. The reason as to why it might be working elsewhere versus here is a strong presence of family physicians and also awareness really about the diseases that occur in the families, and pretty much here disease awareness and cancer awareness is quite something new here. So I understand, and it makes sense. We have many people with very interesting histories that they can't really get beyond maybe beyond the grandparents or the great grandparents. So it's really it's really key to know the history. And this is something that has to be joined with any other efforts that you're trying to make. Having a base of family physicians practice here, and also knowing the history has to be joined with whatever thing you might be doing downstream in terms of genetic testing and all the screening that goes together with it. So I agree with what she asked, what she mentioned. It's a very critical thing to have all the history ready. Beyond that, we will be it's just could be just a waste of time.
Yeah, it is certainly challenging. I think if there isn't if the family does not know the history, or if patients were not diagnosed, if people die from things that they might not know exactly what family members died from, and I think we have to start somewhere. So it's like you go with what you have in the moment. I'm sure a lot of people on the call are familiar that in some cancers there are now recommendations for universal testing for germline mutations. That might not necessarily be feasible right now in many parts of Africa, but depending on what some of these preliminary studies show, so like the studies being done in South Africa or Nigeria, and the one that is about to start in Rwanda, I think that would certainly help give guidance for this specific context in different countries. So, depending on what the rates are of pathogenic mutations, is this something that should be considered for some cancers in a universal manner, which could potentially help with some of the limitations with knowing family histories. But it is, family history is limited, and you just go with what you have.
Thank you. Yeah, these are, as I think most people are probably getting from this conversation, this is not a clear, a black and white situation where you always know exactly what to do. There's a lot of interpretation and subjectivity that comes into these decisions. And that's why, first of all, genetic counseling is so important, because the ability to interpret some of these results and make medical decisions is something that you really have to have some understanding and training to do well. And that hopefully some of this course will help that, to become clear and help your practices. I wanted to go to a couple related questions about genetic testing in cancer patients, because this is something that's become quite common. There's one question about treatment of cancer. And the one commenter is saying that the ASBRS, I'm not sure if that's the African Society for Breast Surgery, I'm not sure which that is, but some panel has recommended universal testing for all newly diagnosed breast cancer patients. And they'd like to know what the panel's impression of this is. And there are also another question that asks about genetic testing to predict response to chemotherapy. And so I think these are questions related to precision medicine and precision oncology. So if a few of you could comment on the use of genetic testing for cancer patients in directing their therapy, I think that'd be really helpful. And it would be good to hear both the medical oncologist from Ashiel and Dio, but also the genetic counseling perspective from Diane and Brandy, if you could.
I'm sure Dio will add to what I'm going to speak about, but starting with a question about prediction of chemo, there is a test. We don't have it presently here, but there is a test done elsewhere for patients with ER-positive breast cancers that tend to have an early disease. So the test is a 21-gene assay. It's called Oncotype DX. It essentially gives a score for patients who could be benefiting from chemotherapy after surgery. So it seems to be really reliable. It has shown good responses for many of the patients that were either started on chemotherapy, or patients who really did not, who had a score that essentially shown that they can't benefit from chemo, and they're still doing well, and the like. We don't have them here, but we have a few patients who went to some other countries before to get surgeries and had Oncotype DX, which predicted their need or not to get chemotherapy. Now, the question about systematically doing genetic testing for all breast cancer patients, I haven't read that particular policy, but I would argue in favor of it, in the sense that it could provide some form of prevention for some people that do not necessarily have breast cancer at that time, but could be family members of the patients that have suggestive genetic mutations. So in a sense that you want to prevent, or in the sense that you want to screen, you can use that. But I'm sure that there are other clinical applications of pretty much testing everyone that have breast cancer for genetic mutations.
Yeah, I was going to add a couple of things. So I think to what Tim was saying earlier, I think, the idea of precision medicine, and I wanted to make a couple of distinctions. So there is looking for, somatic mutations in the cancer, and then there's looking for germline mutations. And I think in both, so there are instances in which somatic mutations can predict response to therapy, just regular systemic therapy, or whether or not the patient will benefit from some targeted therapy. But there are also instances in which germline mutations also can predict response to therapy. So I think, the test Ashil mentioned earlier, Oncotype DX, is not necessarily looking for germline mutations or hereditary mutations. We're looking at things that are characteristics of the tumor itself. So, there's certainly benefit to doing these things when they are available. So I think the sort of the huge elephant in the room is, it doesn't sort of matter what we think is important and necessary. If it's not available, you might not necessarily be able to really implement it. So, there are different thoughts with regards to what should be the threshold to recommend, say, universal germline testing, say for a particular cancer. A threshold of about 10% of those cancers being involved with some sort of a germline genetic mutation has sort of been around the number that people think is a reasonable threshold. So if 10% of the population that has that specific cancer also have a germline mutation, that sort of is a threshold people think about as something that is reasonable for universal testing. So in the US, in some cancers, for example, pancreatic cancers or ovarian cancers, or some subset populations of breast cancers, there's the idea that universal testing in those populations can in fact help you identify things that you would not have identified based on the risk models that people are using to determine whether or not someone should get testing. So certainly these are much more complicated decisions and conversations. Really the presence and the capacity to do this testing also matters, because even if there were a guideline, if there isn't the capacity to do it, then it might not necessarily happen. So.
Brandy, could you comment? Do you have a sense of how much the germline genetic testing is being done in patients to determine treatment versus patients without cancer who are just being assessed for risk? I know that treatment in cancer patients and the decisions used around germline genetic testing have increased a lot recently, but I'm not sure if we know how much people are actually using this to make treatment decisions these days.
Yeah, I don't know that we have those data or a good way to identify those data, but it's certainly the trend that we are seeing, that there is a push really to start considering doing germline testing of all cancer patients, both for therapeutic implications as well as identifying future cancer risk and cascade testing. And as was pointed out, so what we're talking about is the American Society of Breast Surgeons 2019 recommendation to test all breast cancers. And that came after a paper that was published that showed when you test on guidelines, following the National Comprehensive Cancer Network guidelines, you find pathogenic variants 10% of the time. And in unselected breast cancers, you find pathogenic variants 10% of the time. So I think there are a lot of important reasons why it is beneficial to consider that. But I also think we, even in the US, have a lot of important bottlenecks. We still don't have enough genetic counselors to facilitate doing all of this testing. Our oncologists haven't routinely been dealing with germline testing, so they aren't necessarily all adequately trained to be ordering and interpreting germline genetic testing. And there's still issues of access to care and equity. So even though the cost of genetic testing has dropped dramatically, it's still not accessible or affordable for all patients. And so I think some of the controversy with this recommendation is that it can really create disparities in care.
Yeah, thank you. That's a really important point. Diane, do you want to comment on, from your perspective, seeing these patients as a genetic counselor, the differences between how you present the information from risk versus when there's a cancer patient in front of you? Are there genetic counseling issues that differ? And maybe you'll cover some of that next week too, but it'd be interesting to hear.
Yeah, I think there are definite differences, especially so for patients with cancer. I think a lot of it depends on where they are at with their treatment. Oftentimes for our breast cancer patients, we might be seeing them the first day. They're also meeting with their oncologist and surgeon because often we want to get results back really quickly if that could impact their surgical plans. Because sometimes women with breast cancer who are found to have a mutation in BRCA or another risk gene might choose a different surgical route compared to if they didn't find one. They might choose to have a bilateral mastectomy versus having a lumpectomy to try to prevent future breast cancer risk. So I feel like patients in that kind of category are typically very motivated. They really need this information quickly, need to know it for their treatment and decision making, but they're also really overwhelmed in that moment with all the other information they're being presented with. Sometimes we're seeing cancer patients when maybe they're at a later point in their diagnosis and maybe they've already gone on a couple lines of treatment that haven't been working for them, that they're not responding to, in which case we might be thinking about this testing to try to see if they're eligible for a PARP inhibitor or some type of targeted therapy. When we're seeing patients who are unaffected, have never had cancer, they can have a lot of anxiety thinking about, they've never been faced with a cancer diagnosis before. They may have seen family members with cancer, seen them go through a horrible diagnosis, and could have a lot of anxiety when thinking about their own future cancer risk. And some people maybe don't want to know that about themselves if they've never personally been diagnosed with cancer. So definitely, take it on an individual by individual basis, but we can see a lot of differences in how to counsel people based on their own history and kind of where they're at in life or in their cancer diagnosis.
Yeah, thank you. So there's actually quite a few questions here that are just great about some of the basic biology of what's going on here. I'll try to take a stab at a little bit of this, but would like to hear the clinical implications of some of this. So can there be a germline mutation without a corresponding somatic mutation? Certainly in oncogenes, we see that all the time. In tumor suppressor genes, we assume that there's a first mutation, which might be inherited, and a second hit that might be somatic, or two somatic hits at a gene. And so there are the biology of these cancer predispositions are certainly well understood, but we don't always know what's happening in an individual. We make assumptions about a person's risk based on their germline presence of a germline variant or not. And so we can, that's something that is we base this around biological knowledge that we have. So in the presentation, it was said that the genetic testing can't rule out complete inherited cancer syndromes. Do you think that could discourage people from looking for genetic testing services? I think this is a slightly different question, but I think it's interesting to ask the clinicians. You're dealing with quite complex information, trying to convey the fact that a person is at risk, but you can't necessarily tell them exactly what's going on. You have to. How do you approach patients when you're dealing with something that's a little amorphous, like hereditary or familial cancer, risk of need for testing, and encouraging people to do the right thing? How do you tell them, counsel them about what to do? And I don't know, maybe Ashila, if you could just start just by saying, when you see somebody who looks like they might need genetic testing, how do you approach that, and how do you get the right message across to them about what they might need? And I'd love to hear from the others in a second as well.
Great question again. So the point here is, as much as you can, you want to state out to the patient that there is something of interest that would mean that they need some form of genetic testing, and this is the approach we're getting with a few patients that we have and that we'll have on the study. You essentially tell them, look, it has been shown before that patients your age with your type of histology and condition usually would be having something genetic in the family. So at the end of the day, it doesn't mean that we will have something, but at least we'll be knowing information if there is, and that also will influence how to manage and how to predict whatever cancer risk that is in your family. Again, we could be having answers. This is now telling the patient again. So we could be having answers on a few therapeutic questions that could be answered as well. There are a few precision drugs that have been discovered and that are being used with patients with the type of cancer you have, with the certain particular genetic mutations. So it could answer a lot of questions. And you might need this testing for the future, even for the siblings, blood relatives in your family. So it's generally something that you do. It's part of the discussion we usually also have with patients when you're starting treatment. You're like, we have treatment for your condition. We could be getting cure or not. So it's never a straightforward discussion to have with the patient, but it's certainly something challenging. And I believe, with the rush of all the information that patients are receiving these days, getting to know a little bit more information about their risks is never something that they would avoid.
Anybody else like to comment further?
If I could just make a small comment that, there's really nothing that we do that is ever 100% certain. So I think, the fact that, it's not going to be 100% certain is part of a lot of the conversations we have with patients anyways. So I think being able to convey some degree of uncertainty and exactly what it is that the test is giving us. So. But I think that's just that's the way. Yeah.
Great. There are a couple of clinical questions here, and I don't know if those of you can answer those. Let me just pick a couple of these sort of at random. There's a question about gene editing, stopping the heritable cancer to save the next generation. I mean, in theory, what you're describing can be done technically. Ethically, the question about changing an individual's germline genetic variation so it will be heritable in next generation to the next generation is certainly quite controversial. and there are ethical issues that need to be considered. We can make the same kind of statement about a pre-implantation genetic diagnoses that are available, meaning you can figure out what embryo has the mutations and choose embryos that don't. There's a lot of reproductive issues here that are complex. And I don't know if Diane or somebody wants to comment on how you deal with reproductive issues. And when people ask about how do I keep my child from having this or my future child from having this, what do you say? How do you approach that? Anyone can answer, but yeah.
Yeah, and I think this is always a really challenging question because we know we get this new exciting technology coming out and we want to be able to offer it to people and people are always interested in it. But it always brings up the question of, well, how do we do this in an ethical way and in an equitable way? Just because something is available, if it's not available to everyone or not available in an equitable way, should we really be offering it? We do have PGD, prenatal genetic diagnosis, available for hereditary cancer conditions. I would say it's a little more controversial compared to things like childhood onset conditions because it's an adult onset, or most of our hereditary cancer syndromes we're testing for are adult onset conditions. So there's a question about, are you taking away the autonomy of that future child in some way by kind of ruling this out? We also know that a lot of these technologies are very expensive. So you essentially have the privileged, wealthy population having access to it and essentially eradicating disease from their families, while less privileged populations don't have that same access. And then you worry, some of these diseases become issues that only affect already underprivileged populations? So I don't think there's any easy answer to any of this, but I think it's all really complicated when you think about it from an equity standpoint.
Thank you. I'm sorry we're out of time. There are some other great questions, but we look forward to having you next week, starting on Tuesday, Wednesday, Thursday. We'll have similar sessions and they will focus a lot on the genetic counseling aspects of the work. But please let me thank our panelists, particularly Brandy Leach, who gave a great presentation today, and also Diane Kohler, who we will see next week, Sheil Manarakiza and Dio Fadelu, who we will also see next week as panelists. So thank you for joining us, and we look forward to having you continue this work and these learnings in the coming week. Thank you very much.